Welcome back to Med Twitter this week. I'm Chris the Chiu Man Chiu, and I've got a great tweet. Dr. Avi Cooper, my friend Dr. Avi Cooper says, why can't furosemide improve dyspnea/pulmonary edema from acute congestive heart failure within minutes of administration? Question mark. The answer does not involve diuresis. We'll talk more with him about this tweet after the intro. All right, welcome back. I have Dr. Avi Cooper, the famous, the infamous Dr. Avi Cooper. How are you doing?
Good, Chris. It's so good to be talking to you.
So I think most people know of you, know of your presence on Twitter, your great threads and tutorials that you've been doing over the last, I think you really picked up over the last half a year even, a little more than that.
Yeah, really in the last 6 months I've been doing it more, yeah.
And you and Dr. Tony Brew and Dr. Hannah Abrams now have this great podcast called The Curious Clinicians, where you guys are sort of culling a lot of the threads that you guys have been doing and then packaging them into podcast form. Is that right?
Yeah, it's really just an excuse for like the three of us to like talk about, fun, interesting medical topics that, that we want to learn more about, and then we record it. So.
Yeah, I just listened to your last one. Was that Wednesday? Was like your episode 4 or 5, and that was it the azithromycin, the anti-inflammatory properties of azithromycin?
Yeah, that was the most recent one, azithromycin. Yeah.
That's good. I really enjoy everyone to check it out. But we're going to talk about furosemide, or probably easier to say Lasix. I don't know. Are we allowed to say Lasix?
Yeah, I think we're allowed. Yeah.
Okay. So when you get ready to do these threads, you engross yourself in just like tons of literature for weeks, I assume.
Yeah, it's like it usually takes me about 2 to 3 weeks to prepare them actually. And yeah, it's like this 2 to 3 week deep dive into a single topic. And I almost always learn something that really, really surprised me that I just had no idea about going in, which is honestly part of the fun part.
What was the first thing that made you interested in to start digging into this? And was this the question you were looking at to begin with? Yeah,
it was. So I keep a running list of questions that come up or things I come across that I want to learn more about and potentially do in a Tweetorial form. And this had been on my list for a while. It originally was something that I had heard about as a resident, actually, where one of my co-residents gave like a really quick like chalk talk teaching session, and it came up that Lasix furosemide has this non-diuretic effect, this venodilatory effect, and it just kind of encoded a little bit in the back of my brain. And for whatever reason, I put it on the list and decided to learn more about it and do the tutorial.
I don't want to spoil it for too many people, but you talk about the venodilator effect and a bronchodilator effect, and the way you just describe it and discuss sort of the proposed mechanism sort of just blew my mind.
Yeah, it blew my mind too, honestly. It's one of those things that Lasix is a diuretic, and that's how you think about it. But looking back, like I have had patients that get better within a few minutes. They feel better, their respiratory rate goes down. It's always kind of confounded because you're doing other things. You're putting them on non-invasive, or maybe you're giving them nitro. So there's like, you're doing other things to make them better too. But I did have that sense that sometimes people just get better faster than they can make urine.
So a lot of times when I hear about venodilator effects, and endotheliums, I think about nitric oxide, and you sort of talk about that there is some nitric oxide effect, but doesn't really explain it all. Is that right?
Yeah, one of the studies that I had quoted had actually studied like a nitric oxide inhibitor, and it didn't seem to block the effect of Lasix effect on venodilation. So it suggested that the nitric oxide piece is maybe less important.
What was your favorite thing that you gleaned in your whole research, and did you put it in the thread, or were there other things that you wish you could have put in the thread that you wanted to tell us about?
Honestly, it was the bronchodilator effect. That just totally surprised me. I'm a lung doctor, and like I just had no idea at all that Lasix works as a bronchodilator. And then when it ended up being the same mechanism as the venodilation, and that the mechanism in heart failure as well, that's what really was like, man, this really ties together. That's a really cool drug.
So I don't know if like everyone, if great minds were thinking alike, or just, he read your tweet or whatnot, but Rohan over at Midlife Crisis had a tweet that came out like, I think the day after yours. And he started off with a poll and said, does furosemide save lives? And the poll results were actually really interesting. 48% of people said yes. And he was talking about, well, the reason why I asked this is because, he's a cardiologist over in the UK, and he gets a lot of junior doctors always regurgitating, well, they always say that there is no actually added mortality benefit to furosemide. And then he'll talk to nephrologists and say, well, it doesn't really bother me if they're on it, whatnot. Did you get a chance to see? I think I shared this tweet right before we started talking about, and I don't know if you had a chance to digest it a little bit, but what were your thoughts on that discussion?
I guess my thoughts are like, that's a study that no one's ever going to do. You're never going to be like randomized to no Lasix if you have heart failure.
Right. I'm not going to like withhold like diuretics on my patients with heart failure, right?
Yeah. So I think it's an unanswerable question, but I'm not going to like withhold it. It doesn't seem right.
Well, did you have any other pearls or things that you wanted to let people know about? Or if I was reading your thread and somehow I missed your last your last tweet with the conclusions, what are the big takeaways you want people to have from your thread?
So, there seem to be, I guess you would call this like an off-site effect, I guess, or an off-target effect of Lasix or furosemide in heart failure. And there was a lot of, actually, it was interesting. There was a lot of discussions about whether or not to should we be giving Lasix to anuric patients who are in acute pulmonary edema.
Right.
That's honestly a question that's never come up for me, and it's not part of my practice, but it was really interesting to see that some people have used, like people were piping up and saying like, I've used that and it's worked. And, so I can't comment on whether or not that's actually a viable strategy. But there is this non-diuretic effect of venodilation, increased venous capacitance that reduces pulmonary congestion within minutes in heart failure. And it seems to be due to prostaglandin effects. And that Lasix also is a bronchodilator. And, it's when people feel better from taking Lasix, they're probably feeling better for multiple reasons. There's also effects on J receptor function and signaling in the lungs. And Lasix has been used just for dyspnea from like end-stage cancer, like lung cancer, in an inhaled form. And so there's probably a multitude of effects as to why people feel better taking Lasix, for when we're using it for acute heart failure, which I think is just absolutely fascinating.
Do we know what the duration of this effect might be, or is it just long enough for the diuretic effect to kick in so that we can finally, then it helps them out in the end?
That's a good question. I honestly don't know.
I guess you could find out if we tried doing the study on anuric patients, right? Then you won't have to worry about the diuretic effect.
Yeah, right. No confounder.
Who do we know over in nephrology who can do this study on, right? I don't. Well, thank you so much for discussing that tweet with me. I'm going to sort of bring up some of my favorite tweets for the week, and then we'll talk about one of your favorite tweets for the week in a second. So some of my favorite tweets of the week include one from CP Solvers. Of course, the CP Solvers are amazing. They've got a great Twitter handle. They have lots of great things there. They have a YouTube. They have a podcast. They're every platform and amazing. And one of the things they're best known for is their schemas. And so most recently, they had a beautiful, beautiful schema on lactic acidosis. I really encourage people to check that out. Dr. Jeff Stetson, who has been on the episode a couple of weeks ago, he had another Tweetorial Tuesday, and they were talking about the hierarchy of teaching skills. And sort of they talk about where the pinnacle is like the large, greater than 5-minute didactics, but you have all the smaller things, including like small pearls, less than 5 minutes, and so forth. And they were saying, what were people's thoughts on their proposed hierarchy and if they had any thoughts on changing it. But they use that because as they start moving on from their discussions on online teaching sort of to clinical teaching, which is sort of their focus for the next several months. So I really encourage people to check out that thread. put in their couple 2 cents, whether they think this hierarchy is appropriate, and continue to follow them. They also have a brand new Twitter handle to follow just their discussions. And so that's @MedEdTwagTeam. So make sure you guys follow that as well. So next is from Dr. Lakshman Swamy, and he has this card game that he's working on getting produced called the Crit Care game. And in fact, I'm actually like a beta tester. I spent like 20 minutes cutting out all these cards. And so I'm still working on a beta testing it. I'm still working on getting dice for it. So once I get that, I'll be able to do some more beta testing. But he's got a quick like 1-minute video on sort of his pitch. So I really encourage people to check that out.
I can't believe that he asked you to cut out cards as a beta tester.
Well, so I actually reached out to him to beta test, and he's like, "Oh yeah, sure." And I think he sent a PDF, and basically it prints off. So I printed it off myself. And
you didn't have a choice.
I didn't have a choice, but definitely I'm going, like, if he decides to do a Kickstarter on this, I'm totally in. So I'll let you guys know how it goes. Next is Ben Schwartz. He had ortho Twitter tips. So basically talking that groin pain really is just hip pain, and lateral hip pain is actually bursitis. So I think I say this all the time in my outpatient clinic, but maybe other people don't know this. But so when people say hip, they're probably not talking about their real hip. So then last is the first ID tutorial from the ID Fellows Twitter handle. And they really looked at the importance of source control when managing persistent bacteremia. So they had this case where they talked about a patient who was on day 3 or day 4 of persistent bacteremia, and they're like, what do you do? They're on vancomycin. Do you change up the medications? What do you do? Of course, they sort of sandbag us because the real answer was, well, there's obviously a source you haven't found to have control of. So that's the real answer. So I would have people check out that thread. So Avi, you brought a tweet that I thought was hilarious. I really enjoyed it when it came up recently. Dr. Moyne is a resident over at MGH Medicine. And so her tweet goes, I read hemodynamic embarrassment in a consultant note for the first time, and my sources informed me this is a normal CCU phrase, and frankly, I'm into it. So have you heard this phrase before? I don't even know what it means.
I have, and yeah, I think it's like somebody who's, goes into shock. And I agree with Dr. Moyne that it's just a kind of, I don't know if it's a lovely turn of phrase. It's, describing an unfortunate event or unfortunate situation, but it is like this, it's eloquent. And it reminded me of one of my kind of favorite kind of short critical care synopsizing phrases, which is metabolic disarray, which just, it sums up a lot. It doesn't in just 2 words. And I just enjoyed I thought her description of the phrase was really well done. And then the thread was interesting as well. We were getting into like the etymology of embarrassment, like the French origins and like its other connotations besides like shame. So I appreciated that she did that.
I'm trying to imagine like someone with hemodynamic shame, just like
right, exactly.
Do you so besides that and metabolic disarray, do you have any other favorite sort of turns of phrase that you learned about since joining medicine?
Oh, I like I've always liked, perfect is the enemy of the good, or the juice is not worth the squeeze. That's one that I use a lot.
I've never put that in a note though.
I don't put juice is not worth the squeeze in a note.
I think one of the phrases that I've always wondered about when I first was in med school and I was doing my rotations in OB/GYN is the use of expectant management. It's like like on every single note is expectant management. I was like,
continue to monitor.
Yeah, continue to monitor. It's sort of like
not do anything about it.
It's sort of like on the other end when I'm getting my consultant note and I'm saying, well, appreciate the recommendations from the critical care team, the pulmonologist. We're going to wind down our discussions today. One thing before you leave us is, what do we have in the horizon? Do you want to give us any teases for possible threads, or even what's in the bag, what's in line for the Curious Clinicians coming up?
Yeah, the Tweetorial stuff can change, so I'm hesitant to commit on air to what's coming next. But our next Curious Clinicians podcast is going to be on why saline is actually abnormal.
Abnormal saline. I love this discussion.
Yeah, and it was based on a Tweetorial that I did last year. And so we do a deep dive into that, and we're going to get into like the origins of saline itself and all the different crystalloid formulations that have existed over the years. And, we're going to talk about like mammalian, like osmolarity, and like how we got here. And it's going to be a cool discussion. So I hope people download and listen.
So you think Plasmolite's going to say more normal saline?
Do I what?
Should Plasmolite change the name to more normal saline?
Or lactated ringers?
I think one of my favorite pieces on lactated ringers was, I think early on, there was a lot of discussions when I was in med school about, I had a medicine attending who wouldn't prescribe lactated ringers because he would say it's so much more expensive than normal saline. And I think several years ago, it was sort of, I think it was an EM blog, and they looked at sort of like the prices, and they're like, it doesn't cost any more than like a liter of Coke. So like, would you rather hold a liter of Coke than exactly? So I actually found it really interesting over the past, not to steal what you guys are going to talk about coming up, but I really find interesting sort of the change in the last several years of when I first started, the internists did normal saline, the surgeons did lactated ringers, and the ED docs, depending on whether they felt like they were trauma surgeons or not, did lactated ringers. And now everyone's just doing LR, and definitely the surgeons aren't, and anesthesia is not doing head of starch anymore either. So,
yeah, it's harder after like some of this, like the SALT ED trial that came out and others. Like, it's just hard to not give like balanced crystalloid at this point, I think.
I completely agree. All right, so I'm going to encourage. So when's that coming out? Is that in 2 weeks?
It's going to come out next Wednesday. Yeah,
oh, fantastic! Don't have to wait too long for that. I'm looking forward to it.
Awesome. Yeah, it's going to be great.
Well, Avi, thanks for spending time with me right after your clinic. I know you're just getting things ready and jumped onto the call with me, but I definitely appreciate it. Thanks so much, man. I'll see you around in the hospital.
Yeah, I'll see you around, man. Take care.
Stay easy. Bye. Thanks again for following us here on Med Twitter this week. I appreciate the time that Dr. Avi Cooper spent with me. Make sure that you subscribe, rate, review, and all the great platforms that are on YouTube, Twitter, Periscope, Apple Podcasts, Google Podcasts, and everything else. Have a good one. See you guys later. Bye.